check for latent TB, and should we give latent TB prophylaxis alongside treatment? So just a thought.
So in that sort of situation, rituximab would be the safest drug because the risk of TB is lowest with rituximab. So it's rare with rituximab rather. Thanks for that comment, sir. Over to Dr. Barney, who has been I think the sheet hanger in organizing this conference. He's a professor and head of pulmonary medicine here at CMC Vellore. Over to you, Dr. Barney.
Yeah, good morning, good afternoon, and thank you, sir, for that introduction. So to make it interactive, I have a practical way. So if you can please get on your phones, I have an app called Slido, which will run through. Same way how everyone did, but just that, it will make sure that you participate. So if you go on slido.com, QR code will come when the questions come, or you can key in the code of the Slido code when you're starting to answer as well. There are only few because my time is very short. So this talk is on IPAF, is it a true entity? And I thought I'll look at 3 cases, but for want of time, I'm only showing 1. And then we look at the nomenclature because that is gone back and forth a lot and still a lot of them linger. We look at the diagnostic criteria which came in 2015 and has not changed much, though there are a lot of controversies which we look at. The epidemiology, the clinical features, radiology, physiology, pathology, is there any role? Is it any different? What is the treatment, the prognosis, any recent advances, and some take-home messages. So all of us have been hearing this from morning, so I'm not going to into the details of this, but what stands out is the idiopathic interstitial pneumonia, and in those ILDs with known association, we have the CTD. And actually, IPAF is that thing that lies in between a clear-cut IIP and a clear-cut CTD. So it is that gray area that is between these two, which doesn't fulfill the ACR guidelines for a CTD, and it is not purely idiopathic interstitial pneumonia. So it's somewhere lingering, and I think research and our thoughts around is also lingering. So there's a lot of learning that's happening, and I've tried to gather that which is from the literature. Okay, so this is the first case, and at the end of this, we'll have a question. So this is a 39-year-old male who came to us just a couple of months back, episodic cough for many years. He had multiple joint pains, but no real swelling, involving both small and large joints, and he had progressive breathlessness for 3 months. That is a CT. The left one is the apical image. Middle image is the right top one, and the right bottom one is the lower image. His ANA was positive and RF was negative. And that's his spirometry. Okay, so the FEC is there at 46%. His DLCO is 39%. He's desaturated from 97 to 91, and his Rho 52 was positive as well on further screening. What is the diagnosis? Please be fast because my time is running out. Don't get biased by the title of the talk. It could be different, okay? Okay, 3/4. Wow. IPAF and CTD are fighting close to each other. Anyhow, that's how in real life it is as well. So here there were no, this patient did not fulfill ACR criteria for a CTD, but he had Rho 52 positive, some joint pains, so he actually was labeled as IPAF. So the nomenclature has varied over the years. Earlier, there was a terminology called forme fruste ILD many years back, where it was thought to be the first manifestation of CTD being a lung manifestation as ILD. And as patients were followed up, they probably evolved into CTD. Then came a terminology, again, this is well known about, is autoimmune ILD. That is, they are not really actually, in today's world, they will not fulfill IPAF criteria also, but they have some autoimmune markers that are positive, but everything else is like a IIP. Then there's whole range of names given for what could be synonymous to IPAF, which is the lung dominant CTD, early CTD, occult CTD, autoimmune featured ILD. These terminologies went about till the 2015 guidelines came and gave this label as IPAF, idiopathic pneumonia with autoimmune features. However, we need to remember that it is a research entity and not a clinical diagnosis. And some agree that it is synonymous to UCTD or undifferentiated connective tissue disease, but I wish to think it is slightly different, because when someone has more predominant CTD manifestation clinically, serologically, and have an ILD, but do not have fulfilling criteria of ACR criteria for a CTD, they are probably termed UCTD. And this was the terminology used by rheumatologists for many years, but now they have also started using IPAF. So I'm not sure whether they use it interchangeably or in their minds there's a differentiation between IPAF and UCTD, but I don't think there's a correct answer. So we are looking at an interface between IIP and CTD, and also there's an interface between pulmonologists and rheumatologists that drive this disease. And I think it's all about the direction in which you're seeing. And that determines what you call it, but doesn't matter, the entity exists. So I saw an interesting article in one of the rheumatology journals saying IPAF, what the rheumatologists need to know. But today we are looking at IPAF, what the pulmonologists need to know. And there is also enough articles which say why the pulmonologist rheumatology collaboration is essential to have clarity in this issue. So briefly going through the diagnostic criteria. So you need to have an interstitial pneumonia on the CT, and it should not have any other etiology, and it should not fall into a defining feature of CTD as per ACR criteria. And then it should have 2 of the 3 clinical, serological, or morphological domains. So clinical domain, we have discussed that in detail. So it should have one of these. Again, one of the criticisms is that this is not an exhaustive list. And if it doesn't fall into this, then actually by this criteria, you cannot call it so. Serological domain is again extensive. ANA requires a titer of more than or equal to 1:320, particularly when it's diffuse speckled or homogeneous. And a rheumatoid factor should be more than 2 times the upper limit of normal, and a whole lot of antibodies. Again, this is not extensive, and that's another criticism about this criteria. Then we have a morphological domain which has got radiology, histopathology, and a multi-compartment involvement. Radiology is all that we know of except UIP. Histopathology is again many things we know of with some additional things like lymphoid aggregates, lymphoplasmacytic infiltration, and then a multi-compartment syndrome. Again, in histopathology, the UIP doesn't come in. So the next question to all of you is, when can UIP be included in the diagnosis of IPAF? Is it when some features are there, or is it you cannot include UIP and IPAF at all? This is, I think, important in the understanding as we move forward and as literature is moving us forward in this area. Okay, again, I think there is so much competition and heterogeneity in saying it is never or any or multi-compartment, but yeah, that's true, because there is a lot of ambiguity, but never is not the right answer. Because if you look at only the table, you will take never for an answer, but if you look into the fine prints and subsequent several articles which have come up on publications in IPAF, there's even an entity called UIPAF now which is evolving. So UIP can be included into the diagnosis of IPAF when you have one of the other morphological domains, which is either a multi-compartment involvement, or you have lymphoplasmacytic infiltration, or interstitial lymphoid aggregates with germinal centers, or some OP, or if the radiology has combination of something else other than UIP, then you can take UIP into the diagnosis of IPAF, and then it goes into what is now emerging as UIPAF. Just looking at a couple of publications which have looked at different domains which have played a role in the diagnosis of IPAF. So it looks like the combination of morphological and serological domains form the major part of diagnosis. That's very typical of patients whom we see. We see patients with IIP, morphological domain attained, and when we screen, we find something serology positive, and they get labeled as IPAF. They may have a bit of clinical manifestations, but what the rheumatologists see is from the other side. They see clinical manifestations, serology, ILD, but it's not fitting in. So that's more likely to be in the center where that 20 patients in the first study is probably more skewed from the rheumatology pathway. And there are enough publications coming up saying the current IPAF criteria cannot stand for too long. It needs to be revised, and probably someone is working on it as we talk. So there are some controversies, which is what we'll try and get some clarity at the end of this talk. Is IPAF a clinical entity or a research entity? Do the domains need refining? We've already answered that. Does IPAF behave differently in comparison with other established entities like CTD-ILD and IIP? Should we treat IPAF like IIP or CTD-ILD? Now, these are important questions for us to answer. There are no population-based studies, but about 25% of systemic autoimmune diseases which present to the rheumatologists actually are IPAF. About 10 to 20% of IIPs which present to us are actually IPAF. And 7 to 34% of all ILDs is IPAF. And that Venn diagram there gives where all it can have some sharing with. And this study beautifully tells us that it is NSIP and OP which have the major contribution to IPAF. Unclassified IIP is the next bidder, and IPF very less because of the negative reasons why UIP cannot be part of IPAF. Clinical features are pretty much the same. This is just to highlight that the age group is somewhere around 50 and 60. Some female preponderance, but it's not universal across studies. And smoking seems to have a risk towards IPAF as well. Radiology and physiology are pretty much similar, but pathology, there is a very good study which has looked at explanted lungs and biopsies that happened in patients would now fulfill criteria for IPAF, and pathology did change the diagnosis in some of them, but I'm not sure it's convincing enough that we need biopsy to treat IPAF all the time. I think this is the last question for you to answer. What is the treatment that we need to give for IPAF? Is it steroids? Is it other immunosuppression? Is it a combination of steroids and additional immunosuppression, or should it be antifibrotics? As most of our answers are going, it's all 50-50, and that is what IPAF is all about. It is 50-50, yeah. So here probably the right answer is we need to go by the pattern, because you have a UIP which can fit into IPAF, you cannot give immunosuppression. So this is just to say that so many things you need to consider. Once you have IPAF meeting criteria, you have to look at what kind of CTD it could be associated, the extrapulmonary manifestations, the severity, multi-compartment, how fast the disease is progressing, the comorbidities and the patient's expectations, all that, and you need to make a decision. There are no focus RCTs because this is actually a research entity. There is only one retrospective study I could come up which has compared and looked at antifibrotics group and immunosuppressive group, and it showed some benefit with immunosuppressions than antifibrotic, but mind you, this was a UIPAF paper. So again, it is retrospective and we cannot give too much importance to it. So the treatment is as for CTD-ILD with immunosuppression. Antifibrotics can be considered only if there is a PPF in a subset, or if it is a UIPAF. And the rest of it is all supportive management. And these are just showing that there is a balance between inflammation and fibrosis that is going on in these patients. Going on to prognosis, about 10 to 20% of these patients move on to develop full-blown CTD-ILD. And we need to remember that this is modulated with a lot of treatment. Actually, if we don't treat, probably a larger percent would go on to evolve into CTD-ILD, but with treatment, about 10 to 20% go. And when they go, half of them are either rheumatoid or Sjogren's. That may be important to know. And the bottom Kaplan-Meier tells us that those who have IPAF have higher propensity to develop CTD-ILD as compared to no IPAF, which is the IIP group. This is a Kaplan-Meier which is looking at the prognosis of IPAF. On the y-axis we have the survival, and on the x-axis we have number of years. The top left one is looking at the 5-year survival. 71% is the 5-year survival of IPAF, and 12.5 years is the median survival. And the B and C graphs are differential analysis. The B is looking at when NSIP is the commonest, but if you have OP along with it or OP in isolation, it has better prognosis as compared to NSIP alone. And the C graph tells us that if there is scleroderma antibodies in patients with IPAF, actually they tend to do worse compared to those who don't have scleroderma antibodies. This is a Kaplan-Meier, which the x-axis is in months, and it's comparing those who have IPAF and no IPAF, that is IIP, and the trajectory is quite different. IPAF do better compared to IIP, even when we take IPF group or non-IPF group. This puts it all in a nutshell. This is a Kaplan-Meier which is looking at the top line is the IPAF. Then is the top line is the CTD-ILD, which has got the best prognosis. The IPAF is quite close to CTD-ILD. Then you have the seropositive IPF. This is like that AI-ILD I was telling about. There's some autoimmune markers, but doesn't fulfill criteria of IPAF. And then finally, it is the IPF, which has got the worst prognosis. This is a meta-analysis which is looking at the risk factors for rapid progression: age, ever smoking, UIP pattern, and DLCO, low DLCO have significant association with rapid decline with IPAF. So to come to a conclusion, we have to take a practical approach. We have a patient who has a diagnosis of ILD, where the etiology is either unknown or unclear. We have to look at the age, the gender, because how you would interpret a 70-year-old male and a 45-year-old female will be entirely different. Look at extrapulmonary symptoms. Look at the pattern of ILD, because UIP, NSIP, OP, they will be dealt with very differently. And look at the basic autoimmune workup we do for everyone, which is ANA and RF. With this, we will be able to decide on what extended CTD workup we need to do. And in our institution, where ANA comes in 1+ and 2+, we also ask for dilutions when it's borderline to know whether it is meeting IPAF criteria of 320 or not. And then we get our rheumatologist input and decide on whether it is IIP, IPAF, or CTD-ILD, and then they go for immunosuppression or antifibrotics, and then we follow up to see how they go. So if I may put a possible spectrum, IIP is in one end, CTD-ILD is in the other end. The ACR criteria helps us to decide CTD-ILD from UCTD-ILD. The IPAF criteria helps us to differentiate AI-ILD from IPAF. But all this is a gray area which is still evolving, but much is known from when the criteria came in 2015. There are newer advances like IPAF, which we mentioned, and there are a handful of articles now with hypersensitivity pneumonitis with autoimmune features as well, which is evolving as an entity. My last slide. This is just our center data from INPF. The first is the IIP, which is the largest, and equal contribution by CTD-ILD. Only 1/3 of that is IPAF or UCTD. But in all of them, NSIP is the commonest. So take-home message is IPAF is a research entity in between IIP and CTD-ILD. It's got better prognosis than IIP, but pretty close to CTD-ILD. The criteria probably needs revision and is probably expected to come sometime. And we need to look for CTD features in all potential IIPs, both clinical and serological. We need to do a logical workup. We need to collaborate with the rheumatologist. We need to treat as for idiopathic and follow up to decide for the plan. Thank you.
Thanks, Dr. Barney, for the stimulating talk. Any questions from the audience? Yeah, Dr. Barney, possibly, effective treatments is probably what is compelling us to make a diagnosis of immune-mediated diseases. So that is what has changed over the past 20 years. And so one of the things is the whole field is quite dynamic because the classification criteria keep changing every 5 to 7 years so that, you pick up more patients and you know exactly which patients to target. Like rheumatoid arthritis in 2011, myositis in 2019. So all those things, one of the main reasons is pick up patients early and then you include more of them and treat them and give the benefit of the treatment benefit. And overall, after all, it is a phenotypic classification we are making for all these diseases. But in this era of personalized medicine and genetics, once you know that, what is the genetics of each of these diseases, probably 10 years or 15 years down the line, that's how you classify the disease and treat. Thank you, Dr. Barney. Thank you for that.